applied diarrheal disease research, which resulted in hundreds of published papers. And he's the senior editor of the book, WHO book of Case Book of Ethical Issues in International Health Research. And in TB DOTS program, he is known for his making history by the community-based solutions for million, making tuberculosis history. And he's a visiting professor of various universities and various places, which include our own Achyuta Menon Center for Health Sciences in Trivandrum, which he visits whenever he gets an opportunity. Over to you, Dr. Richard Cash.
Well, thank you very, very much for that kind introduction. I wonder if can you all see me? Am I visible to you all? Can you hear me? Okay. Well, let me thank the organizers, first of all, for putting together such an exciting program. It's a huge honor for me to be able to attend and to return to Kerala, even though virtually. I have very fond memories of spending time teaching at the Achyuta Menon Center and continue to maintain friendships and relationships with people in Kerala. I thought the previous speaker gave us a really excellent discussion of what has happened in terms of IMR in Kerala, and rather than repeat that, I thought I would take a somewhat view from above and take a look at this issue from a more global perspective. I first came to South Asia in 1967 when I joined the ICDDRB, or actually it was then the Cholera Research Laboratory, and to do work which eventually led to the development and testing of oral rehydration therapy. When I first came to Dhaka, the infant mortality rate was about 150, and now, 53 years later, it's down to about 26, with an under 5 mortality of 31. The maternal mortality rate, which is much more difficult to lower, was in the 800s and is now down to about 150, 160. So how did all of this take place within such a short period of time? And the same thing has happened in many other areas of India. Well, first of all, there is the proximal determinants. High rates of immunization, including immunization of mothers for tetanus, with tetanus toxoid. There were wards of patients with tetanus when I first joined 53 years ago. Low-cost treatments, oral rehydration therapy, for example, nutritional inputs, both with certain vitamins, folic acid for women and vitamin A for certain children, increased primary health care with a huge increase in the number of health manpower and the availability of drugs and treatment, many of which, of course, are given inappropriately, but some actually hit the mark. Better birth attendance, better MCH factors, and so on. All of these have contributed. And as we have watched the infant mortality, it has gone down steadily. It hasn't suddenly precipitously dropped, but it's been a steady downhill look. But then we have to look at all of the distal determinants, all of those factors outside of the health system. Better roads, electricity, a huge input from maternal education, women's education, particularly at the primary school level, women's empowerment, women in the workforce, age of marriage going up, and then in the health sector again, family planning, birth spacing, age of marriage increasing, agriculture. All of these are what I would call distal determinants. So it's a steady downward movement. I looked at this back when I was a visiting professor in Japan, and it went through the same process, although there weren't immunizations in those days. This began in about 1918, and they had reached parity with the United States by 1965. So the same slow process takes place. What I think is very critical here is that it did not depend on the health care system, but on the system of preventive medicine and other determinants of health. And I think that this is very important. The health system itself can take us so far, but then much of the improvement must come through all of these other factors. Now, Kerala, as you have just heard, has done a remarkable job in so many areas, not just of health prevention, but also in issues of literacy, almost 100% literacy, issues of women's empowerment, better roads. I remember the first time I came to Kerala, I was really struck by how everything was interconnected to everything else. Water, sanitation. I remember taking students up to the Tata Tea Estates in Munnar, which had achieved, even though people were still living in the same line houses that they had lived in before, and when infant mortality and so on was astronomical, this had all come down through a really excellent system of both primary care and also immunization rates and so on. And for those of you who've never been up there, to see the system up in Munnar was just very exciting. But other things, education of the girls, postnatal care, breastfeeding, all of these factors came into play, which were absolutely critical. Now, so I don't want to overstress the Kerala situation, because all of you have heard about it. But as I say, within Kerala itself, there are also very exciting experiments and not experiments, but implementations that have gone on through the years. And again, Munnar is a classic example of this, which was a wonderful template for others looking to improve their primary healthcare system. But then what do we compare Kerala to? What is the comparator? I often see papers where Kerala is compared to the US, a very bad comparison, by the way. Kerala spends about $150 per person. The US spends $10,600 per person. And the infant mortality rate, by the way, is almost identical. But the other comparators that people have mentioned is certainly Sri Lanka. Sri Lanka, although it has a slightly different healthcare system, much more government-oriented, still the other factors, education, status of women, roads, electricity, all of those other distal determinants are very similar to Kerala. And also within Asia, Malaysia, as people have mentioned, Thailand. I think if Kerala is to take lessons from anywhere, it's from the east that it should look, and it's south rather than to the west. I remember when I first visited the Kerala Museum in Trivandrum, how many of the artifacts in the museum were actually from Indonesia, Sri Lanka, and so on, not from the north of the country, but Kerala was always looking south to its through its trade routes and so on. And I believe that that in the future, in terms of increasingly improving its position, which is really quite remarkable. As I note, your infant mortality is not much different from the US. UK is 4, and so on. So you should be justly proud of what you have achieved but you will achieve greater lowering, if that is your goal, of course, is in those factors outside of the low-cost primary health care interventions. It will not be through high-level tertiary care. That will not lead to a dramatic lowering, but is through the steady, slow economic, social, political development that it will come about. And it is through that it has come about. I think I will stop my comments there and look forward to the comments of the others, and to thank the speakers who preceded me with such an excellent discussion of IMR in Kerala. Thank you very much.
Thank you, Dr. Cash. Our next speaker would be Dr. Vivek Virendra Singh, who is a health specialist with UNICEF, which is coordinating the health systems policy and program interventions for child health at UNICEF India country office. He has been instrumental in national implementation of National Polio Surveillance Project of India, and also in Africa, especially in Kenya's expanded program of immunization and polio eradication program. He's a faculty of Indian Institute of Public Health, which is engaged in the development of course content for competency-based training programs. And he is involved in the public health surveillance, public health program management, policy advice to the state governments, and planning of maternal and child health programs. He has worked in public health emergencies and also in strengthening early warning and response systems globally. Over to you, Dr. Vivek Virendra Singh.
Thank you, sir. Am I audible? Thank you for the generous introduction, sir. And I'm honored, as UNICEF as well, we are honored to be associated with this conference, and the Honorable Health Minister and other dignitaries present here today. So at the outset, as Professor Cash also mentioned, that our previous speakers have made our job in this panel easy. And I would pick up on the title, the SDGs, Dream or a Reality, and put things in perspective for Kerala. I want to share some slide pointers that I have. Can anybody confirm if my slides are visible?
Yeah, visible.
Thank you, sir. So as I said earlier, that we have heard from our speakers throughout the conference, and everybody is trying to put things in perspective for Kerala. But let me point this out at the outset, that Kerala as a state in India should also have lessons from Kerala. So more than, what are the benchmarks and standards for a state that has already reached the aspiration of India in the India Newborn Action Plan of a single-digit NMR, for example, a decade ahead of time. So while it should set its own benchmarks and standards, I think there is a lot that the other states in the country as well as the region should also learn from Kerala. Now, everybody has mentioned about this, that we have seen during the Millennium Development Goals, the amount of reduction that we saw in the infant and maternal mortality. Probably what we are not going to see, because as it gets lower, we are not going to see this and during the SDG period. And this is the time when it will be difficult for every incremental gain that we want to achieve. So I think this was a fair comparison when we heard that if we want to compare the health systems in Kerala, in the region, to Sri Lanka for various reasons, and as Professor Cash also rightly mentioned. But having mentioned Thailand, we must also acknowledge the fact, and I heard Dr. Virod from Thailand in the conference, that with this kind of an event of Kerala conference, I compare it to the annual event that Thailand has, which is called the Prince Mahidol Awards Conference. And it's a global diplomacy event where Thailand, with its public health system, with its achievement in universal health coverage in the region, is able to take the lessons to other countries and also bring about some very useful changes through the World Health Assembly. For example, we all know that Thailand's work around human resource for health and some of the interventions they have been able to make are quite well known. So I think this kind of interaction that we see during this conference of our fraternity colleagues from countries like Thailand coming in is very welcoming. Now, again, just to re-emphasize on the point that we have seen the decline after the advent of National Rural Health Mission and the fiscal and other resources inputs that we started seeing in health. And if we remember the idea, the ethos behind National Rural Health Mission when it started in India was commutization, taking health to the people. And I think that is where the social model of Kerala has been successful of what India envisioned to do as a state. We have seen that what that can do to the health indicators, and we have seen the corresponding decrease in Kerala. Now, coming to the core subject, maternal child health, SDGs, whether dream or reality. So we have heard enough about the global level. Now let's come to the India level. And one of the speakers in a panel, Dr. Rakhi, who will be speaking shortly. So one of the work published by the Global Burden of Disease India chapter, which does the state disease burden, recently they just published a 17-year trend of what are some of the districts in the country that might, at the given annual rate of decline, might not be able to achieve the SDGs. This does not mean that they will not, but this just means that they will have to do things differently, and they will have to do things differently at a scale to be able to meet the targets. Now, as we have seen that causes of newborn deaths, which is 8 out of 10 in Kerala, 80% as well, for a state like Kerala, now the state disease burden group gives us the opportunity. For example, if you see the highlighted portion, and not surprisingly, as our previous speakers have also mentioned, we see the increasing congenital malformations and the neonatal preterm births and the mortality due to these cohorts increasing as the NMR reaches the single digit. Now, here is one point that I want to make, and let me pick from what Dr. Kamath was speaking in the previous intervention, where he said that every child should celebrate its first birthday is what Kerala should look at. I would add that let us pledge that now if the infant mortality has already reached 10 and the newborn mortality has reached 8, let us now pledge that every child does not just see the first birthday, but sees the first birthday with best of developmental milestones. And I think that's the next step which states and countries like Kerala that have achieved low newborn mortality should reach out to, for making sure that each of these premature babies who, because of our system's ability to make them survive, have survived, they also develop to their best possible potential. And that is where taking the agenda from just the survive to survive and thrive comes in. So I think this is one area where states like Kerala can inform others. Now, another important point when I mentioned that in states like Kerala, we need to take these lessons to other states. So if you see that as, for example, again, taking the case of newborn mortality, if we club the states according to the current NMR, we see that, let's say, single digit NMR in the green, if you see. So what are the kind of interventions you would need to further reduce? So high risk referrals. Are we identifying the high risk kids, referring them properly? Further strengthening of the tertiary care, maybe congenital malformation specific things that we all know need to be done, pediatric surgery, competent nursing. Now, this is something where I want to pick that last year was declared to nurses and midwives in India, and a lot of these gains are now going to come from the competence of our nurses in these specialized care settings. And I would also further add that, you know, perinatology as a specialty, both for physicians and nurses, which the other states who are still high burden might not be, where there is still making up for the skilled attendance at birth. So where there is less scope of trying such specialities, states like Kerala can do it. But the most important point that I want to make is that when we see in these boxes, what are the additional incremental gains that are going to come by these intervention, it does not mean that everything else which is mentioned for high NMR states should not be done. So that plus this, which means that you will have to continue reaching those newborns, reaching those kids, reaching those mothers at home during the antenatal period for the mothers, postnatal period for the mother and the baby, both. Now, how do we achieve it? Recent Lancet Commission, which said, what is the high quality health system which can help achieve the SDGs in the SDG era? And this is again where there are both lessons for and from Kerala that can come. We all know the social security and other community empowerment, local governance type of actions in the states like Kerala. Now, here is the opportune time for high quality in our health system, where quality impacts from the perception side of the community is given equal importance. And it is based on population health needs. And we need to do transformative actions for workforce and reimagining our service delivery platforms. Because once we have reached these stages, the next gains are going to come from our equity focus. That are we missing those that will continue to be missed, as you said, maybe when we see a stagnant line for almost a decade. So our next focus should definitely be equity. And in the same Lancet paper, if you look at people who bypassed the public system and who cited at least one quality concern, so we also see that there were samples drawn from all the states in India, and there could be lessons for everyone. Then another important point for such states is that making UHC a reality for SDGs. Although universal health coverage is one of the components within the SDGs, but let's look at it upside down, that with UHC, we can only achieve the health-related SDGs. And it's not surprising if you see in the highlight box where I've tried to show India with the Iceland, Israel, Italy, some of these developed countries in Japan. Not surprisingly, you see all of them in blue, whereas for many of the service coverage indicators which were drawn for this UHC index, India, we see a lot of scope for improvement in many of these. And similar indices, I think the states can also continue looking at to see how they are performing. And then what are some of the actions for these high quality health systems, as we are calling it? So foundation again, and some of the things which are good in Kerala, that govern for quality at all levels. Now that people are coming to services 100%, as we heard from the previous speakers, are we delivering these services with absolute perfect quality? Redesigning service delivery to reach the unreached if there are equity issues. Transform your health workforce, maybe more midwives, to have these services nearest to the community as possible, the ethos of primary healthcare. And then population, ignite the demand for quality. People should come forward, and we could strengthen in community outreach, primary care, hospitals, emergency medical services, and referral. And I think states like Kerala can focus on referral and emergency medical services, which are still catching up a lot in other states. And some of the final points, and I think enough has been said, but it's worth re-emphasizing the fact that it's only through the primary healthcare approach, which has three distinct approaches within PHC, that integrated health services with absolutely well-aligned referral, with an emphasis on primary care and essential public health functions within the health workforce available to the communities as near to them as possible, then empowered people and communities, which I think is a very good background already in states like Kerala, and then multi-sectoral policy and actions. So I think drawing again what Professor Akash said, that if we remember, there was a call given, health in every policy. So, in fact, there's a write-up also by a lot of eminent members from India that wrote about health in every policy, the same WHO principle which was given around that time. So focusing on the primary healthcare, and as I mentioned that in Kerala, we can try out things like perinatology, maybe strengthening the midwifery cadre, the nurses on the front lines for these. And finally, I just want to remind that, when India set up the India Newborn Action Plan in 2014 in global response to the Every Newborn Action Plan, India, in fact, was more ambitious than the global targets and said we would want to achieve single-digit NMR 5 years ahead of the global timeline, which is SDG 12, but India has 10 by 2030 in INAP. And what I want to remind the audience here is that Kerala was already under 10 when INAP was being formed. But there is a component within an INAP and vision where we can still work in states where we have such low NMR, which is if India envisions a health system that eliminates preventable deaths of newborns and stillbirth, and where every pregnancy is wanted. So the importance of birth preparedness, as somebody rightly mentioned, that newer issues like mental health in mothers. So if we are working with the mothers for birth preparedness, which was such a basic thing, we will catch up with these new kind of issues that are emerging during that birth preparedness process. So where every pregnancy is wanted, where every birth is celebrated, and where women, babies, and children survive, thrive, and reach their full potential. Last but not the least, we have seen what COVID can do, and I deliberately did not bring that point up because we all are still studying as states and countries the impact it has had. So let us not forget that for the SDGs to make this dream a reality, and yes, it can be done, this decade was already declared a decade of action before COVID happened. And how will we be able to achieve these global goals? By mobilizing everyone and everywhere. And I think COVID response and in states like Kerala has shown the importance of whole of society approach. And I see the professional associations also represented and speaking in the conference. So mobilize everyone, everywhere, and demand urgency and ambitions, because we'll have to redouble our efforts in this decade of action because of the regression that COVID has brought about, and design new innovations and be pragmatic in these new innovations. Thank you very much.
Thank you, Dr. Vivek Virendra Singh. Let's move on to the next session. This is by Dr. Ahmad Reza Hoseinpour. He's the Health Equity Monitoring Lead at WHO Geneva. He has conceptualized and coordinated the development of resources and tools in this area, including the unique tool HEAT, which stands for Health Equity Assessment Toolkit, a software application to explore and compare health inequalities. And he's involved in the WHO Handbook on Health Inequality Monitoring. And he's the lead author of a number of peer-reviewed articles quantifying the inequalities in health, both in country level and global level. And he's very enthusiastic to use the interactive data visualization in order to effectively communicate health data with diverse target audiences, which is showcased in many WHO global reports. Over to you, Dr. Reza Hoseinpour.
Hello, everyone. Thanks very much, sir. So it's a great pleasure to be here and to talk about inequality monitoring. And my talk today has two parts. In the first part, I'm going to give you a short presentation on importance of inequality monitoring with a couple of examples, as also came up nicely by Dr. Vivek just in the previous talk. and also then give you a live demonstration of a toolkit that we have developed to assess situation of inequality in countries. And we are going to showcase India as an example. So equity is at the central of Sustainable Development Agenda with the aspiration of leave one no one behind. And it's already reflected in several SDGs. SDG 10, of course, is the main one to just reduce inequality within and between countries, but also it's reflected in SDG 1, 4, 5, and 3, of course, health. And we have the target 17.18, which calls for building capacity for disaggregated data in countries that are reliable, timely, and high quality. So recognizing the importance of inequality monitoring and data disaggregation for equity-oriented policies, programs, and practices, WHO has developed tools and resources to support countries for monitoring of health inequality with collecting, analyzing, and reporting on disaggregated data. So I'm going to give you a couple of examples here. The first one is WHO Health Equity Monitor, which is one of the largest equity database globally. And this database is developed and launched in 2013 and has been updated annually. And currently, it includes over 30 health indicators, mainly from the domain of reproductive, maternal, and child health, disaggregated by 6 dimensions of inequality: economic status, education, urban, rural, subnational region, and age and sex wherever applicable, based on reanalysis of more than 450 international household surveys, which were collected over past 3 decades in 118 countries. And they are interactive visualizations and country profiles there. The second example that I'm going to give you is the toolkit, Health Equity Assessment Toolkit, that I'm going to just share with you a live demonstration of that quickly. So here is the toolkit, Health Equity Assessment Toolkit. Just checking with you, can you see my screen, please?
Yes, we can see.
Okay, perfect. So Health Equity Assessment Toolkit is around 2 concepts, 2 areas: explore inequality and compare inequality. In explore inequality, we are going to look at the situation of inequality in a country of interest in terms of its latest status and change over time. And in compare inequality, we are going to compare the situation of inequality of one country of interest with other countries. So let's start with explore inequality and looking at disaggregated data. As you can see it here, there are several tabs on the right side, which I'm going to just show it, just some examples of that. And on the left-hand side, we can see a selection panel. That from that selection panel, we can pick up the country of interest. So I can here just go and pick up India. And you can see we can define surveys or data sources we have, different years, and also we can define different indicators here. So here, currently in the current view, we're looking at a stillbirth attendance in India over 3 periods for which we have publicly available data from National Family Health Family Survey, NFHS, in 1998, 2005, and 2015, from Health Equity Monitor database that I just described for you. And we can see here on the x-axis the coverage of a stillbirth attendance from 0 to 100%, and in y-axis the year of the survey. And we can define here different dimensions of inequality. So for example, I can pick up economic status just only disaggregated by 5 quintiles. So this is known as wealth quintile. And we can see here for each survey, for each year, we can have 5 data points showing the coverage of a stillbirth attendance in each of the wealth quintile, from poorest quintile to the richest quintile. And we can see here in 1998 and even in 2005, there was a large gap between poorest quintile and richest quintile in terms of a stillbirth attendance. But the good news is that in the latest survey in 2015, the gap between poorest and richest has decreased quite significantly. Of course, as we can see here, still there is a relatively large gap that requires to be increased. From left panel, we can pick up other indicators from that list. So for example, if we consider stillbirth attendance as an indicator, proxy indicator for maternal mortality, let's pick up an immunization indicator. So DTP3 immunization coverage that influences infant mortality. So here we can look at infant mortality. We can look at DTP3 immunization coverage by wealth quintile. And as we can see again, there was a relatively large gap between poorest and richest in the previous surveys. But in 2015, in the latest survey, the gap decreased significantly. We can also pick up different dimensions of inequality, like education and place of residence. So immediately with this interactive visualization, we can capture the situation in the country quickly in terms of different health programs and also different dimensions of inequality. For example, for DTP3 immunization coverage, we can see in 2015, there is almost no difference between urban and rural areas. We can look at it from different angles, this sort of visualization. So for example, if we're interested to see what are the differences between the states in India, we can go to the horizontal bar here, and we can see the situation in different states. So we can also sort it by, let's say, different indicator, let's say by a stillbirth attendance, and so on. And we can also look at compare inequality. So not only we can see the situation of within country inequality in India, we can see where India stands in terms of inequality comparing to other similar countries. So the toolkit by default picks up the same income group countries and the countries from the same region. So low middle income Southeast Asia was taken. And if we look at the benchmarking, the comparing inequality here, we can see while by itself there was a large inequality, wealth-related inequality for skilled attendance, comparing to other countries in the region that had data more or less the same time, 2014 or 16, similar to India, then other countries had much larger inequality. So it always helps to look at benchmarking to see where the situation of inequality stands. We can also look at it in another view, because we always say national average is also quite important. So in this view, we're looking at skilled attendance again, and in the x-axis we have national average of countries, and in y-axis we're looking at inequality within country. In this case, the difference between poorest and richest quintile in each of these countries. And we can see that in terms of national average and within country inequality, India is doing quite well in the sense that this area shows the area that has larger national average and lower inequality. So we can also highlight different countries, naming them, and we can add to the situation. And always with the tool, we can also download the data as a visual, as a image or PDF and put them in the reports, or download the data that is behind that. So that's just showcasing the situation that we have in our health equity monitor database. But also the point is that the toolkit has another version, which is called Heat Plus. And with that version, we can see the situation in terms of different data sources that we have. So the toolkit that is called Heat Plus, users can upload their own data. So if we have data at subnational level, let's say within each state, we have data that also can be uploaded. And instead of comparing situation of India as a country with other countries, we can look at the situation of Kerala in terms of inequality, comparing it with other states. Or if we have more data, even at district level, we can compare inequality at district level within Kerala with the tool. So the point is that what we would like to do is that to make sure we know about the situation of the disadvantaged population, and that's important for the planning. So with using this tool, we can plan for that, and we can see what are the points that requires priority and action. The toolkit can work also not only with surveys, but also with different data sources like facility data, CRVS, and also census data. And as I said, it could be used at any subnational level. And broadly speaking, it can use any health, any indicators, health or beyond health. So can also look at different determinants of health and look at disaggregation of those tools as well. Thanks very much.
Thank you, Dr. Reza. Let's move on to the next session, and that is going to be the last session of this panel discussion. Let me welcome Professor Rakhi Dandona, who is a professor at Public Health Foundation of India and professor of Health Metrics Sciences at the Institute of Health Metrics and Evaluation, University of Washington, US. Dandona has over 2 decades of experience generating evidence on disease burden and risk factor distribution at the population level through epidemiological studies. Professor Dandona is the chair of Global Burden of Disease Study in India, Injury Expert Group for India, State Level Disease Burden Initiative, collaboration between ICMR and in fact more than 100 other institutes. The initiative's research on gender differentials in suicide has received a lot of reviews. Her work on as part of evaluation of large-scale neonatal health interventions in Indian states of Bihar and Uttar Pradesh has generated robust evidence for stillbirth estimation and health system-related risk factors for stillbirths in India. She has had several researches funded by grants and has more than 200 peer-reviewed publications. She is the associate editor for Journal of Injury Prevention and serves as in the editorial advisory board of Lancet Psychiatry. Over to Dr. Rakhi Dandona.
Thank you very much for that kind introduction. I hope I am audible.
Yes, you are audible.
Wonderful. Thank you so much. Thank you. I must say that, you know, given that my primary work is a lot in Bihar and Uttar Pradesh, and I'm so used to dealing with mortality statistics that are double digit, you know, this presentation for Kerala was a very unique and very proud experience where we are talking about single digit numbers within India. So very pleased to be part of this panel. Thank you very much for inviting me. My presentation is built around, you know, what we know of infant mortality and neonatal mortality and what evidence do we need more to reduce it further from the single digits that we already have. The overview of the presentation, I'll take you through the mortality burden, inequity as we understand, cause of death, and then lastly talk about morbidity as many of these babies continue to survive. The under 5 mortality in, these are the SRS numbers, is 10 currently in Kerala. This is the IMR and this is the NMR. So if you look at the proportion of NMR now within the IMR, that's about 70%. And IMR within under 5 mortality is about 70%. So the idea is that if we work more on NMR, reducing NMR, our IMR is likely to come down much faster than we keep it as IMR as a broad category. What do we understand in terms of inequity? Inequity we can see in many different ways. One is looking at inequity in terms of geography. SRS tells us there is slight inequity, but this is not significant between rural and urban parts of Kerala, which is 5 and 7 respectively. We know from, I think Dr. Vivek Singh mentioned that our group has done this work of district level estimation for under 5 mortality and neonatal mortality, which was published in Lancet last year. If you look at this, these are all districts of India. The more red they are, the worse off they are. And it's very interesting to see, as all of us know, the blue parts are basically centered around Kerala when you look at under 5 mortality or you look at neonatal mortality. Now, if you look at this in detail from the Global Burden of Disease study, we see that the variation even within the districts of Kerala is actually not much. And the variation that you see is actually statistically not significant because the confidence intervals overlap. Having said that, it's important to know that these are all modeled estimates because we do not have robust estimates for district level, you know, primary data availability for district level at population level in India. This is the gender differential for IMR. As you know, SRS does not give gender-based data for neonatal mortality, but here clearly the gender differential is seen where the IMR is higher for boys than for girls. We do not have differentials available by social groups. other than, of course, what the population-based surveys, for example, like NFHS give us. But the issues with those data are that the sample size is not enough for us to robustly estimate the actual differences between the social groups for IMR or for NMR. But we would need social groups, the differences by caste, by socioeconomic strata, or whatever is relevant social group that is applicable to Kerala. We would also need robust estimates by place of delivery, public sector and private sector. NFHS 5 tells us that about 40% of the deliveries in Kerala is in public sector and the rest in private. So it would be interesting to understand how the IMR differs by their place of delivery. And of course, by gestation period, given that preterm births are an important contributor to the IMR in Kerala. One way to build evidence around these social groups is from the health facility data. Given that most of the births, almost all of the births in Kerala happen in health facility, we need to integrate data variables across these groups and what else we need within the health facility data and start looking at those data to understand what do we find as differentials by the social groups or by place of delivery or by gestation and other clinical factors. And given everything is mostly computerized health facility data, these are the kind of differences that we have to make now. Start using these data for this single digit IMR and NMR to reduce further. There's only so much that we can make a difference now in these numbers based on, or these rates based on population level data such as NFHS. If we were to assess population-based data, which has its own contribution and own risk factor assessment, we would then need much larger sample sizes, robust surveys for a given period, and collect data on recent births. For example, NFHS takes births in the last 5 years, where the sample for recent births is really small. So we would need population-based data for recent births, large enough samples, which we can establish baseline and population level for these differentials that you see here, and then use that for improving changes that are needed further. Cause of death, many of the previous speakers have talked about cause of death. I won't spend much time on what the differences are. The differences are fairly visible, where congenital birth defects really are a big concern in Kerala, which is true in other developed country settings as well, as you take care of more of these infectious and other perinatal conditions. If you look at this a bit more in detail as we go down, urban rural, the difference is not as much, but here is that difference by neonatal deaths. If I remember, I had mentioned that 70% of IMR is neonatal mortality in Kerala. So if you look at neonatal deaths, most of them are here, the neonatal disorders, the preterm births, the birth asphyxia, and trauma. And this attention on this, along with attention on congenital birth defects, is where we need to go. The activities that are already happening in Kerala, the strategies that are already in place, are in any case built towards addressing these causes of death. And in fact, even much more than what one would have anticipated. The activities that are currently on are actually fantastic. What we now need to do, if we need to go down further, is to start looking at this cause of death by, what are these potentially avoidable causes of death? And how are these causes of death influenced by the conditions that are in the population or in the community? To do that, I've broken it into two, the facility-based evidence and the population-based evidence. Facility-based evidence, we now need to start looking at, just not look at the death reviews, the maternal death reviews or the child death reviews or the neonatal death reviews. We need to start looking at the clinical risk factors across all births and to see which of these births are likely to die, because you have the live births and you have the births who've died. So So the understanding of risk factors now is needed across all live births and clinical risk factors, which is why NFHS is not going to help us much here, because NFHS does not collect clinical risk factors, which is where we have the importance of strengthening the clinical documentation for each case, so that we can start looking at clinical risk factors to see how we can change what is needed at the facility to make sure that these babies survive. Similarly, at population level, I've already mentioned, we need baseline assessments that actually allow us a baseline assessment to understand what the risk factors and inequity are at this point in time, which we can then, in collaboration with facility evidence, use it to find the policy that we actually need for disease prevention. One of the important things to go further down to reduce the mortality is to understand the cause of death better. The cause of death, medically certified cause of death in India happens only for less than 25% of the deaths, and Kerala is actually around 12%. Medically certified cause of death will take us really in that direction of understanding what actually needs to be done, because verbal autopsies can only tell us this much. Even within the verbal autopsies that we use currently, there are standard forms available. For example, the World Health Organization's verbal autopsy form, or the PHMRC form, which allow us to generate standardized data, which allow us to generate the cause of death in a more standardized manner, so that Kerala can actually compare its cause of death over time within Kerala, and also with other similar settings using verbal autopsies. So cause of death needs improved documentation. The other way to look at cause of death is also, as we are doing verbal autopsies, as we are trying to understand why these babies are dying, to keep an eye out for symptoms, signs, and abnormal findings that don't fit anywhere. For example, sudden infant death syndrome. Many of us have started to hear about it. Many of us have started to talk about it. For example, in our primary work in Bihar and UP, mothers simply tell us in verbal autopsy, baby had milk and baby slept and baby never woke up. Baby was all fine. So there are ways to start accumulating evidence for even causes like SIDS, and there are verbal autopsy ways of doing that. So I think Kerala needs to start building evidence around these emerging causes as well. Stillbirths is kind of missing from the agenda. We've talked about MMR, we've talked about NMR, but there's also stillbirths. These are babies who are nearly full term. There's a definition for stillbirths, beyond 7 months of gestation. And the rate of stillbirths in Kerala is not that different from the rate of neonatal mortality. So as Kerala starts to work towards reducing NMR and IMR lower, I think Kerala could also start focusing on how to reduce the stillbirth rate further, because many of these stillbirths are actually preventable. Lastly, if this is what I saw in the ebook, and Kerala is already doing fantastic in time to see how to address these causes of death, which are very different from what the other Indian states do. But as we continue to see these causes of death, and some previous speakers have also mentioned, we would need a variety of specialists. And if you look at this figure here, it clearly shows that you also need an ophthalmologist in addition to someone who's specializing in delivery and antenatal care. You also need someone who's a hearing expert, and there would be much more specialist needs as we continue to make sure that these babies actually survive and not die. The health system needs to be integrated. It cannot simply be a delivery system as these babies survive. It would need rehabilitation and disability along with the delivery services. So survival and rehabilitation and quality of life has to be built in. The health system needs to become a child-friendly space, because these children will need more access and more space to visit health system for maintaining their quality of life. And of course, the access needs to be closer to home. This also means that the kind of research that we do in Kerala starts to become different. The research in Kerala needs to work across a variety of these issues so that it can actually reduce the mortality further. And I did hear some of this already in some of the previous presentations, but I think as a policy program perspective, we need to invest more in across each of these to make sure that the numbers go down further. Lastly, all this is also going to change community level needs. After we talk about mortality, we need to start talking about morbidity. These babies will survive. More of these babies will survive. So the community participation in all the actions is very important. The community perception and integration of these babies into the community is very important. And I say this because we do understand, already issues with integration of people who live with disability. The child care services, education and welfare services would need to expand to make sure that these babies have good quality of life. Thank you.
നമ്മുടെ ബഹുമാനപ്പെട്ട our Minister for Health is joining us. I invite our Honorable Minister for Health, Shailaja teacher, to address us and address the panelists who are online now. Madam.
Yes. Dear friends, I want to express my immense pleasure to the speakers who correctly introduced or explained the actual facts about the MMR and IMR reduction. And as you explained here, Kerala also declared our goals for MMR and IMR reduction. These indices actually points out the health, actually importance of health. And in Kerala, according to the Sustainable Development Goal, we also declared our goals on MMR and IMR reduction. When we examined in 2016, the IMR in Kerala is 12 out of 1,000 live birth. But we started to, or we declared the aim to reduce it to single digit. And I'm very happy to see that the IMR reduced it to 7, that is declared in 2019. And now the NFHS survey, latest survey shows that it go below 5. We should examine it properly, and we can say that now we are in single digit and we want to reduce it more. And MMR also, the central government declared to achieve the aim of the UN goal, Sustainable Development Goal, that reduce the MMR up to 70 by 2030. And Kerala declared 30 by 20 and 20 by 30. That was our aim at that time. And we worked hard on that. And when 2016, when we examined, our MMR is 67 in 2016. But it reduced to 43 when we examined in 2020. And the central government gives some certificates on that. And we got 2 certificates. One is for reducing the MMR below the declared aim of the UN, and also to achieving the lowest MMR rate in India. And that is also a very good achievement in health sector. But as the speakers, I didn't listen to everybody, but I listened to Dr. VP Paili and also Dr. Kamath, but I was too busy today and I can't listen everybody. And I left the meeting when Vivek Virendra started his speech, and I cannot listen to everybody. But Kerala is doing so many measures to reduce MMR and IMR. the delivery points, that is the most important thing. And we strengthened our delivery points according to the Lakshya standards. Central government declared the Lakshya standard for the delivery points, and we started to improve our delivery points in Lakshya standards. And also we declared so many projects to reduce MMR and IMR reduction, especially for IMR, the Hridyam project, as the speakers mentioned here, that to address the congenital heart disease and the congenital diseases. And that also became a good achievement to reduce the infant mortality rate. We had already done more than 1,600 operations under this project, and most of the operations, 99% it to become success, and that way also we were able to reduce the infant mortality rate. And for the mental health also, I think the maternal mortality, it happened because there are so many reasons, but the NCD has an important role on that. That the hypertension, diabetes, etc. Now we are trying to reduce the NCD also, and that way also we can reduce the maternal mortality rate. And the mental health, it is also a important thing, and we are giving counseling and classes to these pregnant mothers, and we are listening to their mental health also. And so many measures we have adopted during these 5 years, and I think we can achieve more good results out of that. I am not elaborating everything, and we have to stop this session in time. And I will listen to your points, and I will get the webinar discussion points from my health secretary and the organizers. And I think we can implement more fruitful things to reduce infant mortality and maternal mortality in future. We can reduce more, and this part also Kerala can become a model to reduce the maternal mortality rate below 20 by 30. That was our aim. And infant mortality rate below 5, I think we can achieve that results in future. Thank you everybody to participate in this seminar, this webinar. And Kerala is looking for the solution for all the health problems, including infectious disease and also NCD control, everything. And with hope, I congratulate and I extend my thanks to all the eminent speakers in the webinar. Thank you all.
Thank you, madam, for sparing time from your busy schedule. We'll go on to the discussion part, which is going to be very short because of time constraints. The HEAT, or that software, that program, that is new to most of us. So I was just listening to that. So whether we can apply to a Kerala situation also, like we have inequality, although inequality is minimum in Kerala as compared to other states of India, there are still inequalities possible, say for example tribal. So whether we can actually capture that with that program or software. So can Dr. Amr Reza please enlighten us.
Sure. Thanks much. Yes, of course. And that's the whole point of having this software application. It has 2 editions, and the edition that is called HEAT Plus basically allows users to upload their own data to the toolkit. And in that sense, the data can be from any level, could be national, but also could be subnational at the state level and below that, district level. And it could also be from surveys, but also from facility data or CRVS or census, or a combination of that. So we did a couple of years ago we worked with Indonesia, and we used different data sources that they had to look at inequality in Indonesia. So in that sense, yes, any data that you have, so that's the flexibility of the tool that can be used. And I can also share with you in the presentation where you can get that. So that's on the WHO website, and perhaps one easy way to just look at it is to Google it for WHO and Health Equity Assessment Toolkit. But I'm happy also to share with you the link, which has also all the documentations, user manuals, and some training videos on how to use it. But to shortly answer you, yes, it's totally feasible, and we already done some work using NFHS5, which is also a state-level representative to look at inequality in Kerala and comparing it with other states. So it's totally possible.
Thank you, sir. And thank you, Dr. Raki, for enlightening us on which are the areas to concentrate on, because the NMR is the major share of mortality. So how to actually plug the possible gaps from the experience of working in various countries and various associations? Well, in which area should we actually concentrate on? Raki ma'am?
Thank you for that question. I think in terms of area, I would put it more as a thematic area. I think we should concentrate on facility, given that most of your births are in facility, and start looking at the data by all live births. Just not look at the data in terms of only babies who die. I think that is what we now need to do to plug that gap. So we understand there would be babies with, let's say, risk factor A who survive, and there would be babies with the same risk factor who die. I think that is the kind of understanding we need to now have in Kerala to try to see where the gaps are and which gaps can be plugged immediately and which gaps would need a bit more of a mid and long-term strategy. So that kind of case, clinical data research or review would be needed.
Thank you, ma'am. And actually, we are doing an infant death audit every month. So we have some data on that. And when we are doing that, we come to a dead end when facing the SITs, because there only the verbal autopsy is possible. Is it the way the world over, or is there any other method? Autopsy, is it a common thing or a routine thing there?
It's not, verbal autopsy, or, they don't call it verbal autopsy, but yes, the conversation is what is typically done for SIDS routinely. The other way to also then, and these kind of conversations that have highlighted around the different parts of the world that, there are issues with the way the baby sleeps, the issue in terms of, the side the baby sleeps, how the baby sleeps, with whom the baby sleeps. So these kind of conversations are the ones that will then allow us to understand what is the proportion of SIDS, but also what could be the risk factors that are, contributing to SIDS death. So at this stage, the conversations, whether we call it verbal autopsy or just having conversations, social autopsies for SIDS is the way to go.
Thank you, ma'am.
Thank you.
Accelerating the reduction of MMR and IMR in low and middle income countries has got socioeconomic determinants coming in the way. So globally, how countries have tackled that? Professor Cash, can you elaborate on that, please?
Sure. Can you hear me or see me, or what would you?
Yes, I can hear you, sir.
My own feeling of looking at health over many years, and I mentioned the study we did in Japan and Bangladesh and elsewhere, is that the health of the population is a reflection of the values of the society and whether society decides to invest in its population in terms of their education, housing, water, sanitation, and so on. Health is simply a reflection of that. And if you really want to reduce things like neonatal mortality and low birth weight, you have to attack it not at the facility level, but rather what happens to women who enter the reproductive age. So it begins when they're babies and through the system. And so I think that the values that a society has, and in Kerala, clearly there is a long history there's a very long history of social interventions, and it is why Kerala did so well in the whole COVID situation, is because it wasn't that you suddenly ramped up the system. The system was in place. The values were in place. The values of equity, making sure that the population was well served, and you don't do it when the crisis occurs. You build up to it over the years, and I think that in fact that is what has happened. It has to continue on, and the values of equity, the values of making sure that people have the maximum opportunities for growth and development, physically and mentally and so on, should be intact. Unfortunately, in some countries, the health system tries to make up for the gap in what the social system should be providing. That's both very expensive, it's not very productive, and it won't get you where you want to go. So I think that Kerala and some of your neighbors have moved in that direction and should continue to do so. This does not require a sea change, but a continuation of what is already taking place. The high mortality and morbidity in some areas of the country are very much a reflection of the level of social development that has taken place in those areas. Not a health system which is not very good in some areas, but that's not where the problem is. The problem is far more in the investment in the people themselves. And I think history has shown us this. Thank you.
Thank you, sir. We have a few more questions, but I think those questions are already covered in the talk. And also we have used up the time allotted for this session. So thank you very much, my respected panelists. And with that, let me wind up this session. Thank you.